can see my screen. Okay, perfect. Let's get started. So today we're going to talk about papillary lesion in the breast, that which is a tough topic. But when you sign out the breast sample, usually you will have this kind of specimen. So you always think about this first slide I attach. So we have 4 different diagnoses. Actually, we have another. The last one is encapsulated papillary carcinoma. And then several days ago in 3 p.m., Dr. Hopkins showed us a solid papillary carcinoma. So there are 2 fall into the last category here based on the myoepithelial cell. So start with the benign. The first one is papilloma. So you can see this yellow dot represents the myoepithelial cell. So we have 2 cell layer. So here we have this yellow dot in the periphery. And then we also have this yellow dot lying on this vasculature in this papillary structure. So this is the papilloma. And then the other one is we have the basic structure of this intraductal papilloma, but we have some focal area. We lose this myoepithelial cell, this yellow dot, and then they also have other criteria to meet the ADH or DCIS. Like in this cartoon, we can see this clip forming. So this is the architectural atypia. And then when we see this focal area, if this area is less than 3 millimeter, we call it ADH evolving a intraductal papilloma. If this area larger than 3 millimeter, we call this DCIS evolving a papilloma. If not in a papilloma setting, we use 2 millimeter as a cutoff. But in a papilloma setting, we use 3 millimeter. So you need to bear in your mind when you sign out to call this ADH or DCIS evolving a papilloma. And then the third category is papillary DCIS. That means in low power, we can see this papillary structure. But actually, this is not growth from the basic structure of a papilloma. It's just like normal variant of DCIS, but this DCIS just grows like a papilloma. So you can see this myoepithelial layer just in the periphery, and none of them you can find in the papillary structure. So this is papillary DCIS. And then for the last one, I just put one label here is encapsulated papillary carcinoma, and then we have another category is solid papillary carcinoma. So the reason we call this papilloma, we just based on this myoepithelial cell layer. They lose myoepithelial cell both at the periphery and inside, but they still have this like well circumscribed pushing border, and then usually the cytology should be low. If you can see any high-grade cytology forming this architecture, usually we need to put a comment to give a suspicious to the provider that we could not just treat this high-grade carcinoma as a TIS, because if just low or in the middle grade and then we fulfill this architecture, we just sign out as encapsulated papillary carcinoma, aka DCIS. But if we have high-grade nuclear feature, we could not do that. We need to put a comment with high-grade feature suspicious for invasion. Even we could not see that in this power. Okay, and then for the first case, anyone want to take this case? I think most of the cases you should know the diagnosis. Or if you don't know, you can just give me the differential, because in the first slide I already give you most of the diagnosis.
Yeah, I can do this one. So
Good.
what we're seeing in the center of the screen is a well-encapsulated papillary lesion. Zooming in, it appears to have myoepithelial cells both on the outside and in the fibrovascular pores themselves. Also not really seeing a lot of nuclear activity with that, but I think this is just a regular introduction pathway.
Yeah, that's perfect. When in low power, we can see this well circumscribed papillary. We already see some red thing. This is a papillary. And then looks like a little bit cystic structure. And then when we recognize this papillary structure, we need to see, do we have any creepy forming architecture atypia? For this one, it seems not, because usually these intraductal papilloma, they can get removed by UDH. So sometimes you will see kind of looks like really BC structure, but when you look more detailed, this uh, glandular structure didn't forming any creepy forming. So they don't look architecture atypia. And then, of course, when you see this perfectly well circumscribed outside layer, you need to see whether we can find this myepithelial cell. They usually either they have maybe a little bit darker nucleus. You can appreciate we have different population. Usually they have this clear cytoplasm compared to this luminal cell. So all of these are myepithelial cell in outside. So far, at least from here, we know this is not a invasive carcinoma, but it could still be DCIS. So we see something inside. Often we need to find the papillary structure here or here, and then we can see we already find two population. You can see some cell with this pale clear nuclear feature, and then clear cytoplasm. So compared to this luminal cell, we already know we have at least heterogeneous population. When you screen all the papillary lesion, and then everything just look like this, so you can reassure this is totally benign. So this is intraductal papilloma. This one is really straightforward. So, and the next case. Go ahead. Yeah, this is exactly what it is. So low power, other just benign. So we just focus on this core. So in this 2x low power, we can see some papillary structure, and then even here. But this one, Sarah mentioned, we may have UDH. When you see something like slick-like structure in low power, you may suspicious for UDH. But other than this UDH area, we also can see something forming, looks like creepy forming here. And then in this power, you still appreciate, looks like there are two populations in the whole thing. But the other population, they like forming these solid sheets and also forming this creepy form. So they are not myoepithelial cell. Before we zoom in, we'll always want to check the outside. Here we can see this myoepithelial cell, clear cytoplasm, and then we can make a distinction between this myoepithelial cell and this luminal cell. And then here more look like a benign intraductal papilloma with some UDH changes here, because it looks like we still can see some myoepithelial cell around the papillary structure. But in this area, something different. We have this looks like creepy forming, and then we also can see, compare this benign luminal cell and this atypical cell. We can see this cell kind of overlapping each other. They do not respect each other's border. But this monoclonal cell, it looks like they respect each other and forming this solid sheet. So this is the tumor cells. You can see they just respect each other. And then another feature is that like here, this one a little bit better. We can see this tumor cell kind of like palisading or around this lumen, and then this lumen kind of a rigid because this is a tumor cell. They usually forming this more rigid lumen here. So this area we have DCIS, and then this area we have probably intraductal papilloma with UDH. This area also DCIS. And then let's see I have some staining here. Yeah, this one is the CK56 to highlight the myoepithelial cell layer in the intraductal papilloma. So you can see in the periphery we have this brown positive CK56 cell highlight the myoepithelial layer. And then inside in this lumen around the fibrovascular core, we also have this CK56 brown staining. So that means this is totally benign intraductal papilloma, maybe with UDH. And then this one a little bit different. We have this papillary lesion, and then we have CK56 and P63. They only highlight this normal gland here. So we have myoepithelial layer in this area, but loose in most of this papillary lesion here. And then the ER also show diffuse and strong. So if it is a benign breast, even intraductal papilloma, ER staining should be something like this. We have some darker staining or lighter staining, show the heterogeneous population, not like this diffuse and strong. So ER staining also can help you whether this is a clonal process in this lesion. Okay, and then case 4 and 5, they have the same diagnosis. We can talk about this one first because this one is much easier. Yeah, this is a really good differential because in the low power we can see compared to the intraductal papilloma, it looks like more blue than pink compared to the first case intraductal papilloma because we have more cells. The cell severity is much higher in this one, and then also well circumscribed and forming this papillary structure. So every time I want to see the periphery first because I can know what it is. So in the periphery, we can appreciate still, we can see it looks like maybe two population. We also have some looks like myoepithelial cell here. You can see this cell with clear cytoplasm, a little bit different from the luminal cell. And then they also have this maybe darker nucleus compared to this one, and then more clear cytoplasm. But without staining, nobody can tell this for sure. Just for HND, yes, you can put a differential like encapsulated papillary carcinoma and also maybe papillary DCIS if we have this myoepithelial cell layer. So from the staining, we can still use P63 to highlight P63 and CK56 to highlight the periphery. We have myoepithelial cell layer. So this is a papillary DCIS, not encapsulated papillary carcinoma. But does it matter? Usually it does not because both of these are just recognized as DCIS, and then that treatment are the same. And then for the luminal cell, we just see this monotonous population around the fibrovascular core. We do not have myoepithelial cell layer. So I think the most important thing, just recognize this is malignancy. And then for the previous one, this one are the same, but this one is really fragmented. I think without staining, it's really difficult to see the myoepithelial layer. I searched this for a while and then find some area maybe show myoepithelial cell layer, but never sure. We have to use the staining. But for this one, we have the architecture atypia. We can see they are forming this fusing gland, forming this cribriform architecture. And then when we zoom in, that's the cell is low grade, but they're forming this rigid lumen. And then they polarize around the lumen. So clearly not. And then all the cell looks like not really overlap each other. They respect each other, distinct cell border. This is also another feature for this low grade DCIS. Okay, and then this one looks like we have the skin. They have this nodule. And then want to take this. Yeah, this yeah yeah this case really straightforward. Even in low power, when you see a lot of lymphocyte around, usually that is a bad thing, not just DCIS, because the lymphocytes are smarter than us. They can recognize small things. You can imagine if you can see this next, it could be DCIS, but when you see the lymphocyte and then you can see this next, or maybe micropapillary structure becomes smaller and smaller, smaller. And then when you go to higher power, you can see they're almost forming this single cell, almost single cell infiltrated. So this is invasive. And then Dr. also mentioned whatever thing you think is structure, that is really bad. So for this invasive carcinoma, that's really bad. You can estimate, you can think of this patient already get lymph node metastasis. So you just need to recognize this shrinking artifact. And then this is one of the characteristics for this micropapillary invasive ductal carcinoma. And then for this one, micropapillary, because it looks like we have papillary structure, but they do not have vascular core. So we call this micropapillary. Okay, next one.
I can take this one.
Yeah, go ahead.
So this one, I'm still seeing an exposed difference time, but there's also an antinodular. And the ducts look very dilated. There seems to be cells of net. It seems to be tumor cells. And if you think a little more, there are fibrovascular pores, but just they're very delicate compared to the other ones. And I feel like it's when you zoom out a little bit, it's more like out a little bit. It's more like a solid architecture that we see rather than the papillary, but it's still papillary. And the cells are monomorphic, round, oval. There is vesicular chromatin and nucleoli. And So it almost looks like a little granular as well. And with all of that, I would go with smaller papillary carcinoma.
Yeah, this is what it is. So Lindsay notice low power looks like we have multi-nodular, but the feature just like all the nodular, we have kind of well circumscribed border, looks like more pushing border, not like the previous case. We do not see really tiny necks around. So one of the things can give us the differential, like could be DCIS, could be something else, until we recognize we have a fibrovascular core. And then, of course, we also would like to see high power whether we can see myoepithelial cell layer. It looks like we could not see that, but as I mentioned, for this kind of lesion, you have to do the staining. H&E, yes, you can try your best to see that, but when you have your differential, you can just use the IHC. The feature is that we can see this dedicated fibrovascular core, and then remember we have some area really nice. Yes, this one, fibrovascular core. This cell looks like palisaded or arborizing around this core. That is one of the feature of this solid papillary carcinoma. And then another feature is that we can see foamy macrophage. And then Lindsay mentioned the nucleus feature. This one is not really perfect like salt and pepper. But the cytoplasm, we can see this a little bit eosinophilic and granular. I think this is another feature of this solid papillary carcinoma, because when we do the staining, they can have typically they can have patchy synaptophysing staining. So when you do myoepithelial cell staining, CK56 or P63, they usually do not have any staining of this. And then this one, because we do not see any suspicious invasive area, so we sign out as solid papillary carcinoma. Of course, mentioned that is shit like DCIS. Okay, next case. This case, I think the hint is that I already give to you triple negative. And then you can also ask for staining if you want a definite diagnosis. And the one want to describe this one.
I could try this one. This is another invasive papillary lesion. Not a whole lot of nuclear AKPA with it. I might be hallucinating some chromatin clearing on it. It doesn't really look like breast carcinoma.
Yeah, you can ask for staining.
Should I get a TPF1 and a PAX8?
Yeah, both are positive.
Okay, then I'm thinking it might be like a papillary thyroid carcinoma.
Yeah, this is exactly what it is. So you need to keep your mind open when you sign out anything, because papillary structure not only in the breast, right? We have John mentioned this papillary thyroid carcinoma. Until we find, oh, this is chromatin pattern just like orphan Annie. So really suspicious. We maybe this power is not that high, just 10x. We may see some nuclear groove, may hallucinate some nuclear inclusion, but not really distinct. But this chromatin pattern is just not look like something in the breast. And then this one, we do not see a small body. If we can see it, we can definitely think of something else. Yeah, so just keep your mind open when you sign out a breast case, not necessarily a breast case, especially the provider usually do not give us a really good history. And then we know papillary thyroid carcinoma is really common. Maybe this patient had papillary thyroid carcinoma for a long time ago. They're just thinking they don't want to put any history for this. So, and then another good thing is that when you see this kind of lesion, you do not see any DCIS. Whenever you didn't see any DCIS, just this carcinoma, you need to think about, uh, is this truly breast? Of course, we can do other staining like the TRPS1 and GATA3 to prove this is the breast. So no DCIS, and then this uh, nuclear feature is not that high grade. And then when you do the hormone marker, ARPR, HER2, all of them are negative. So it will also uh, make you thinking maybe this is not a breast, because this low grade cytology feature, they had to be ER positive. But if it turn out to be triple negative, it's really suspicious, not from the breast. Okay, next one. This one I do give you a staining, ERPR positive. Yes, this is a high-grade serous metastasis to the breast. Yeah, when you see a decent number of breast cases, you're just thinking, yes, this is papillary structure from low power, but it looks like really messy. Usually, even like high-grade breast carcinoma, not that, because in this part we can see a lot of slick-like area, and then around this slick-like area, we also can find really large area like necrosis, and then the cell just falling apart. Looks like a really high-grade carcinoma. Uh, yes, in the breast we can see some high-grade carcinoma, but not that ugly. And then I give you ERPR positive. If the breast carcinoma that high-grade, they really likely to be baseline feature. That means triple negative, ERPR negative, and HER2 negative probably. But this one ERPR positive. So and then we can see a lot of this mitosis everywhere, and the cell is really pleomorphic, and then no definite DCIS in this lesion. So and then you will do a bunch of staining. So for this one, you can have PAX-A positive, WT1 positive, and other breast marker like TRPS1, GATA3 negative. So if the provider gives you the clinical history of high-grade serous, it's really easy. But based on this marker, you can also to go back to tell the provider probably not from the breast. This is a high-grade serous carcinoma from the breast. Okay, we have the last two cases. All of these are easy. Anyone want to take? Or I can just go through it. So for this one, we have two diagnoses in this sample. So in low power, we can see a lot of these small nests of cells. They may be forming some maybe papillary structure or micropapillary structure or just solid sheets of growth. And then we have another piece like this forming this solid nest. Let's see this area. We can see a little bit myxoid area, myxoid material, and then this cell just like floating in this myxoid area. So, and then the nuclear feature just like low grade. So when the cell floating in this mucin material, we will call this mucinous carcinoma. But in the breast, especially this one looks like a core biopsy. If we do not have this piece, and then you see all of this piece, we need to sign out this ductal carcinoma with mucinous feature, because a true mucinous carcinoma, the definition should be more than 90% of the surgical specimen, and this is a core biopsy, just maybe representative of maybe less than 10% of the whole tumor cell. So you just could not tell the provider the diagnosis is mucinous carcinoma. You have to sign out ductal carcinoma with mucinous feature, because the true mucinous carcinoma, we think about really good prognosis for the patient. So you could not definitely call it mucinous carcinoma in this core biopsy. And then this is one educational point from this core biopsy. Another point is, well, even this is a surgical path sample, and then all of these like this, you still need to grade the nucleus. If you can see really polymorphic, tons of mitosis, really high grade feature, you also cannot call this the mucinous carcinoma, because by definition, mucinous carcinoma should be low grade nuclear feature like this one. So this is another point. And then always not forget this piece when you get a biopsy. So this piece, we can see the one really similar to the previous case. That is the micropapillary invasive ductal carcinosis. When you see this string artifact around this nest of cells, you always think about micropapillary carcinoma. So when you sign out mucinous feature and then micropapillary feature, that means the prognosis of this patient should not be really good because of this fragment. And then the last case, this is a true mucinous ductal carcinoma. Mucinous carcinoma, because we can see pool of mucin and then the cell floating in this mucin. And then when you scan the whole slide, you just can see this cell forming this cribriform architecture, and then the cell is not that high grade. So if all the specimen more than 90% have this feature, we can safely call this a mucinous carcinoma of the breast. And then I think that's all for the case. Thank you, everyone.